Welcome, everyone. Thanks for joining us today. We're excited to bring a lot of information that we hope is going to help you think about dreaming big, assuming you can see our slides. This particular slide is something to really kind of frame as we move through our discussion today. We really want to help you evolve your program, your virtual programs, as you think about where you are today in terms of the maturity of your existing digital program, whether you're beginning a program or you're actually wanting to mature it, it doesn't matter. We are going to outline a whole bunch of information for you today. Hopefully you have some paper and pen or your computer ready to take some copious notes. And we're so happy to be here with you today. So before we get started, I just wanted to cover a couple of the topics. Great, thank you. So we're going to move through some introductions, but before we do that, just to kind of high-level overview this introduction slide, we're going to be talking about grant funding, how to get it, with our grant expert, and note that that's going to be a very high-level overview, and there'll be some opportunities for you to populate the question section in your application. So if you are not finding that question section, if you go to your little control panel, you'll see a bunch of gray menu items, sharing, webcam, questions. And so you click on that little arrow of questions, that drops down a box, and you can populate your questions in there. For right now, all of the attendees are muted, and depending upon how robust our questions may become, I will end up unmuting so that we can have some discussion. So look forward to that. So we're going to talk about that grant funding. We're going to move through a high-level overview of some of the clinical use cases and their relevance to your business, so that you can be thinking about, again, where you are today with your program, depending on what role you are in today. If you are helping others create their programs, those use cases, we believe, will really help start to cultivate some ideas in how to leverage these funds. And then to wrap it up, we're going to pull it all together by discussing how to operationalize virtual services, no matter the use case or the care setting. So think about the whole continuum of care. Think about your end user experience, whether the end users are your patients or providers, and even your administrative teams as well. So with that, would love to start with introductions. Maria? You're muted, Maria. I think.
Sorry about that. I did what I was supposed to do, not have background noise. Thank you. All right, thanks, Megan. Maria Ingram here, and I'm a healthcare solutions consultant with Pexip. And because of Ironbow's deep healthcare expertise, we're very excited to be part of this discussion today. For those of you who don't know, Pexip is the underlying foundation or video engine for the solutions that we're talking about today. A little known fact is that Pexip powers over 50% of virtual encounters in the United States. We'll talk a little bit more about that later. So for me personally, I've worked with collaboration and infrastructure technologies for 4 decades now, and I most notably manage the Department of Veterans Affairs for Cisco Systems. So Denise, over to you.
Thank you, Maria. Good afternoon, everybody. My name is Denise Hawka. I'm the clinical lead here for Ironbow. By trade, I'm a registered nurse with over 25 years of healthcare experience in a variety of healthcare positions across multiple care settings. I'm here to lend subject matter expertise around, clinical design, workflow implementation, training, to guide some best practices within industry. I assist and partner with our clients to develop some KPIs and key metrics to drive improved clinical outcomes and ROI for the customers we serve. Andy.
And I'm Andy Henshaw. I'm the manager of Pexip's Grants Assistance Program. In a nutshell, I assist organizations with finding and securing federal, state, and local funding through various opportunities for their initiatives and implementations.
Great, thanks. And I'm Megan. I'm an account manager with Ironbow, and I'm also moderating today's roundtable. And we, Ironbow partners with Pexip because of its platform flexibility. And together we really focus on enabling workflows and think about this from the perspective of all workflow possibilities that really virtual encounters, connecting providers with patients is just one of those workflows. So think about Pexip as the engine and Ironbow as all the wraparound components to get that car driving. So if you think about, hardware as the tires and software as the computer chip, services, things like that. So we are going to get things started with our first topic, and that's this high-level overview of grants. Andy?
Yeah, I'm just going to reiterate a very high-level overview. We'll get into the details of each opportunity more toward the end of today's webinar. So we're just going to be going through 4 potential funding opportunities. Of course, there are more, especially with all of this stimulus funding that's coming out. But I thought that these 4 programs would be really appropriate to talk about today, especially as it relates to telehealth and other uses for the Pexip platform. So the first that we'll dig into is the FCC COVID Telehealth program. Many of you all have probably heard of the first round that was established in 2020. They're going to be doing another $200 million round for that, which should open any day now. The applications can be up to $1 million with 0% match, again, per application. The next would be the USDA Distance Learning and Telemedicine program, which has been going on basically since I've been in the grant writing space and grant management space, a little over 20 years from what I can recall. This year, they're having about 60 to 65 million in funding, and the deadline is most likely going to be in early June. Again, that's a $1 million application, but with a 15% match requirement. In the most recent American Rescue Plan stimulus package, the USDA was allocated an additional $500 million for the Emergency Rural Healthcare Program. So we don't really have a lot of details on that, but I think it's worthwhile to discuss just because it's a familiar program for us being in the USDA. And we have adequate time to prepare various use cases, and they have given us some detail about where those funds can be used for the eligible purposes. And then lastly, and probably most exciting for the near term, is the Hersa group, Health Resources and Services Administration, has allocated $6.1 billion in funds that have been distributed currently. It's a very expansive program in terms of the use cases. And so, keep in mind as we go through all of these different business scenarios that those funds, if they were allocated toward your group, could very well be used for any one of these scenarios. So just a quick note, again, with these various funding buckets here, it's important to note that for each of the funding opportunities, it's really important to focus on the use case first for your organization. It's going to provide a lot of strength to your application, and it'll allow you to align the needs of your organization with the particular funding type. So again, focusing on that use case is going to be really important for not only the programmatic purposes, but for the equipment and technology that you choose to put into that solution. With that said, we can dive deeply again into not only the funding opportunities after this, but also we're just going to walk through 3 to 4 scenarios if we have the time that may help you formulate your own use cases if you don't have something in mind currently. And really the idea behind all of these is to focus not only on the standard of care, but the continuity of operations and helping you as a health system improve your business and reach more patients, hopefully again improve the standard of care, but also focus on the business aspects of making that possible with these funds allowing for that large capital expenditure to start the implementation.
Thanks, Andy. That's a great introduction into our next topic. And we really worked as a team to identify use cases that not only are our customers and prospective customers aware of, or maybe they're not aware of, but some unique conversations I think drove us to selecting these particular use cases. Andy, before we get started, I wanted to circle back to can you generally speak to how complicated or not it is for our customers to actually apply for grant funds? Again, just kind of high level, just kind of level set expectations.
Sure. I mean, if you've never done it before, it can be daunting because it's, typically when you receive the application guidance, it can be anywhere from 60 to 250 pages of just rules you have to follow. So I always say that it's best to be a good rule follower, and, it's good to be a good writer too, but if you can follow just every item that they have, what we see in a typical year is that, between 30 and 40% of applications don't even get to the scoring round because they're rejected because they didn't include a certain form, or, didn't have the right numbers matching up between their, their standard SF 424 form, which is like how they contract with the federal government, and then their budget that they wrote, painstakingly. So it's a bit of a letdown, to get to that point and just to be rejected. We can certainly provide that assistance, but again, just to kind of simply put it, read through the guidelines, make sure everything that you're reading through, you have a checklist to go through that. And, as long as you follow the rules and read through, their guidance, you should be okay. And typically you as an organization is going to know how you want to use these funds and, how to tell your story the best. And what we can provide on the back end is review and editing, really just kind of that second or third pair of eyes that's going to allow you to be sure everything's lined up, all the I's are dotted and T's are crossed.
Thank you. That was actually going to be one of my questions to you. So, and then one last question before we dive into the use cases. Does an entity, an organization, whether it's a hospital system, a small critical access hospital, skilled nursing facility, do they need to have a grant writer actually to apply for a grant? Do they have to have that grant writing expertise?
It helps for sure. If you've done, 10, 15 grants in your life, you start to notice some commonalities in the structure for all of them. They typically want to know how does the expertise of the facility and the people who are undergoing the project, how is that going to contribute to the success? How are you guys going to do reporting? How are you going to, request financial information or outgoing metrics, for the benefits of the program? How skilled are you going to be in actually pulling this off? So that's a common element. Demonstration of need. So the populations that you intend to serve, are they super low income? Are they rural? Are they high minority? I mean, intellectually and developmentally disabled? Like any of these things, we're not going to know kind of from the outside. You guys are going to know that best. And so typically if you have someone who is willing to kind of put pen to paper, organize their thoughts, we can kind of address that without a grant, specific grant writer needed.
Great, perfect. All right, well, wonderful. So we're going to shift gears just a little bit, and again, keeping the grants in mind. Andy's going to chime in as we're moving through these use cases. So really, this is designed to highlight what is possible clinically so that you can think about new implementations and ways to enhance your existing virtual programs. We're going to be discussing as we mentioned, four separate and distinct use cases and the business challenges that they can potentially solve. Also note that because behavioral health services are in high demand, you'll likely hear this clinical service being referred to consistently. And additionally, this service really adds a lot of relevance, as I'm learning from Andy, to grant applications because of the needs in our population. So Denise, let's start with Edie Triage. This has really become highly relevant in the time of COVID with, of course, the ED surges and also contemplating for protection of both patients and providers. So can you help us understand why this particular use case is important and what kinds of business challenges it may solve?
Sure. So we all know in the healthcare environment, obviously ED throughput is super important, especially as Megan mentioned, some of the challenges that have come up recently around isolation and exposure and PPE and things like that. So it's more important now than ever for us to get our patients in and out and for us to appropriately disposition them. So if we're able to offer some improved subspecialty services to assist with the triage and throughput of the EDs, we're able to free up some of the beds that may be taken up by low acuity patients and fill them with higher acuity patients, which in turn will improve quality of care and will generate some revenue.
Thanks, Denise. And so what happens, like, for example, let's say there's a facility that may have 20 beds in its emergency department, and all beds are taken, and there's a slew of folks in the waiting room. If we think about introducing, a digital program or virtual care, some organizations are using those terms synonymously. Could you talk a little bit about that workflow and what the experience looks like for both the provider and the patient?
Yeah, so typically, if an ED is filled up and, they're bursting at the seams and they have patients, taking up beds in the hallway, they'll be put on diversion or bypass at a certain point because they can't take any more capacity. However, a way to free that up is obviously to have the availability of the subspecialist for the non-acute patients, right? That maybe need to be put in a room and triaged, and we could beam in or provide a telehealth visit from that subspecialist, provide the appropriate discharge instructions and follow up, and then allow for, like mentioned earlier, the higher acuity patients to actually go through triage and be admitted to the floors appropriately.
Right. So it's really about, establishing the appropriate level of care in that particular environment, right? Because if everything's clogged up, the hospital systems are obviously financially making money when they're admitting into their inpatient rooms, right? So you don't want to have a person with a rash come in and clog up a bed. So that's really helpful. And Andy, could you talk a little bit about which of the grants that you highlighted in our first topic discussion, which one would best apply to this particular use case?
Absolutely. Yeah, it seems like FCC Cova Telehealth is kind of just nail on the head for this specific use case. It's, overarching goal is to reduce the burden on emergency departments, as those have been overloaded with COVID cases, making sure that the sickest individuals can be treated, within those available beds. You can see that from a more metropolitan aspect of, seeing that higher volumes obviously are going to occur in places like New York City or Los Angeles. But from a rural aspect, you're looking at fewer beds available. So, and, along with that, if you go on bypass and you have to go to another healthcare facility, that could be as much as like an hour, hour and a half away. So if you're thinking about the ability to, not only, like you were saying, from a business aspect, fill those beds with the right people and get them into the right treatment, but you're talking about a standard of care as well that's going to be maintained with those funds. So telehealth can definitely be an aspect of that for triage, for treating the worried well who may want to come in because of that minor rash that can be treated, just with a video visit. Or in some cases, just alleviating the concerns of people who may have something that could become more aggressive or acute over time if they're avoiding healthcare. If they don't want to go into the emergency room for any reason, they're scared to get COVID, but eventually the condition gets so bad that they have to go into the emergency department. So there is a way to kind of satisfy all those requirements with the FCC COVID telehealth funds. Another one that's, I guess, not quite as nail on the head, but you can still use it for that exact case, would be the USDA Distance Learning and Telemedicine program. Again, that focuses on more of the rural populations and highly impoverished groups. So you just want to keep that in mind for the use case, the right population to serve.
Right, and so a lot of the questions that we are getting, I think collectively, trying to help serve our customers as best we can, standing up these digital programs is for the FCC COVID telehealth grant, and I know it's coming, right? We're waiting for the money. We know it's coming, and I think there's been a lot of chatter about when. We're not exactly sure, but the primary question that at least I'm getting is, okay, so does there have to be a high incidence of COVID in that particular, let's say, the hospital, in order to actually justify the request of these funds? Is it specific to COVID cases, or are we talking more about more general population health?
I would say, I mean, the most recent guidance, we're not sure if it's a real thing yet or if they're going to continue with the rules from last time, but COVID impact is definitely a concern. It has COVID right in the title there. But there's also an emphasis now from all the comments they received through the FCC portal for geographic spread. You know, a lot of the funding went to, let's say, like Cedars-Sinai or Mayo Clinic or something like that. They received, you know, upwards of $3 million. That created these kind of large buckets of funding that went to, you know, specific, seemingly small areas of the country. Now there's this emphasis on, you know, potentially like one application per state. We're not exactly sure how that's going to pan out, but there is an emphasis on geographic spread. But along with the COVID impact, you know, you definitely want to demonstrate that, or just the preventative measures that you might want to take to eliminate the possibility of COVID being a huge issue there. There's also low-income areas, tribal areas, medically underserved areas, or HPSAs, mental health lack of service in those areas. And so you can kind of demonstrate your point for what the need is, along with the potential for COVID to impact your area, or if it's already impacting your area.
Yeah, and Andy, thank you for that. So when we talk about COVID impact, exactly to our point, there's a lot of people residing at home. There's a lot of children homeschooling today. So there's many people within the population that are not actually going to healthcare facilities for their care. They're staying at home because they're trying to avoid COVID, number one, and number two, they're possibly don't want to overburden the health system. So they don't want to go in there and impact the bottleneck even further. So they're not caring for themselves at home as appropriately. And the exacerbation of any chronic disease state becomes worse because they wait and wait and wait. So the need now for triage and care for these populations is even higher. And that falls in to the category of, you know, COVID impact.
Thank you. We did have a question come in related to funding. Is this relative to just US companies or outside of the United States? Andy, if you know.
So I primarily focus on US funding, potentially a little bit in Canada, but I guess reading through the American Rescue Plan, that glorious 5,600-page document, that was such a fun read. I did notice that there was an additional $750 million for global health through the CDC. So I know very little about it, but there is at least one provision within the American Rescue Plan for stimulus funds that will go to global health. And I would imagine, just based on, I don't know where this person is based, but there may be several funding opportunities within their country or to cross borders, depending on where you are.
Awesome. Well, I know we actually have some attendees from Italy, so buongiorno. That's pretty fun. That's wonderful. I'm not sure how that happened, but thank you for joining. And also, just very quickly, as an attendee asked if this was going to be recorded, and yes is the answer, and it will be available within 24 hours for you to listen if you need to jump to another meeting. So, all right, that's great. Thanks. We're gonna move on to our second use case, and this is a pretty popular one these days, and I think probably one of the most probably challenging for hospital systems who have been engaged, particularly in the virtual encounter space, in the acute side of things or the inpatient side of things. But this is all about home health. So as we're talking about under the umbrella of home health, think about use cases like post-operative visits. You know, some of the business challenges that we're trying to solve here and helping our clients is to, you know, navigate that patient, contain that patient within that hospital system so that those patients aren't out migrating, right, or leaking to other competing hospital systems. And then also the most common phrase that all of you likely know is remote patient monitoring. And so that's more of a traditional home use case, and that's really been widely opened up due to reimbursement for those particular types of visits and those particular types of patients. So I'm gonna lean on our clinical expert, Denise, to talk a little bit more about this opportunity. Denise, why is this all important?
Thanks, Megan. So I think we touched upon this a little bit in the triage situation, and pretty much to Megan's point, we talked about chronic disease management, And it's more about a proactive approach versus a reactive approach. And if we could continue to care for our chronic disease population, we could lower the bottlenecks and the patients that are coming into our EDs and our urgent care clinics and exacerbation of these chronic disease states. So, for patients with CHF, diabetes, hypertension, COPD, those types of disease states, if we're not doing a better job at getting ahead of it and streamlining remote patient monitoring biometric data back to their care providers and managing their care from afar, we're going to have more admissions, and the health systems have penalties associated with those readmissions for these chronic disease states. So it's in everybody's best interest to care for, to provide better care for these populations.
Yeah, so
Denise, I looked up an interesting statistic. I think, just based on the conditions that you were mentioning, approximately 5% of the patient population can account for as much as 50% of the healthcare costs accrued. And I think that quite a few of those conditions that you mentioned kind of fall into that 5% population. So this can very much help. And what was the statistic you said? It can reduce healthcare expenses by maybe like 50% or something like that?
So RPM programs are shown to reduce readmissions by as little as 50%. So 50% and above,
Wow.
readmission rate has been decreased because of RPM management from home. Also, daily adherence, like 90% patient daily adherence has improved. Because what happens is that this patient population that historically has chronic disease states have become non-compliant or complacent, so to say, with their disease, and they think it's normal. It's kind of normal now at this point for themselves. So if they have hypertension or CHF, they're used to the state that they live in, and they're not realizing it's an exacerbation possibly of the disease state that they're in until some of the biometric data is able to be fed back to their care team, and then the care team can make adjustments based on that. So in order for there to be an intervention there, we're able to avoid some readmission and, as I said, exacerbation of these disease states. So we're able to intervene a lot quicker in the plan of care. Staff satisfaction obviously is improved because the patients are in a better state and of health. And then reduction of length of stay, because if we could catch it sooner, they're going to be admitted and discharged sooner if they do have to have a readmission. So there's plenty of benefits to the remote patient monitoring aspect of care. We also can start streamlining that into social determinants for population health and monitoring more at high risk populations versus chronic disease states already, so that we can intervene prior to a chronic disease state and provide some education ahead of time.
So thank you, Denise. So I love this because actually some of this is scripted, some of it is very organic. Actually, most of this is organic. So every time I connect with these folks, I learn something. But Denise, what I'm hearing you say is that we have kind of two underpinning I guess philosophies when it comes to healthcare. We have population health that we've all talked about, and I think that's tied to reimbursement and creating complete compliance and right, and you address those things. And then we have this notion of wellness. I think surrounding all of that, really one of the goals here is that we're trying to help our audience understand how they can leverage technology, right, to address those things. And if you talk about workflow, right, workflow is the key topic here these days. And where we used to talk about just virtual encounters as really the only workflow underneath the umbrella of virtual care, can you talk a little bit about, specific other workflows that might apply here that are outside of just a virtual visit with a provider?
Yeah, so I think today, telehealth, as we know it, has been around a long time. A lot of health systems have now finally adopted to it. However, to your point, Megan, it's not just about the virtual encounter, the audio video encounter itself. It's about the digital health capacity of a digital health platform. So what that kind of means is we want to engage the patient in empowering them to take control of their own care. So like patient portals and online scheduling and launching of educational components and you know, following the patient along that continuum of care where we can meet them in the home and we can educate them preoperatively and postoperatively, and then we can follow them into the acute space and provide education and care for them postoperatively, and then into the post-acute space where maybe they follow them to rehab, and then we continue to follow with physical therapy, medication management, all of those steps along the way. So digital health is really where we're going, and inside of that is the synchronous and asynchronous video components, the text messaging, the messaging, you know, leaving a message for your doctor, medication management, as I mentioned, scheduling, and EHR integration. So a little bit of all of that.
That's awesome. Thank you. So that really speaks to the power of the platform, right? And the infrastructure. And we're going to touch on that actually with Maria's expertise a little bit later here. So Andy, before we move on to the clinical service use case number three, definitely want to understand from your grants expertise, you know, what would be the best grant to apply for related to this home health opportunity?
Really all that I mentioned right at the beginning. Will enable some input of remote patient monitoring. Again, FCC COVID telehealth program is you know, a shoe-in for that sort of use case. Again, for you know, preventing readmissions or chronic conditions becoming worse, having to overrun the ER when it's already overrun with you know, COVID cases. The potential for vectoring, especially for people with high risk ailments, you know, that can be a huge detriment to a health system. So that's definitely a good use case for that program. USDA distance learning and telemedicine is going to be a little bit more complicated because you then have to switch to what's called a non-fixed application, which means that you kind of isolate these devices to the last physical location that is affiliated with the health system. And then from there, it goes out to more of like the residences, right? So you just kind of have to make sure that you word the application appropriately, but it still is an eligible use of those funds. So we can get into that later. I think my contact information will be at the end of this. And if you guys have any additional questions or want to get started on an application, I can certainly walk you through those steps. If you want to, you know, apply for a rural area, rural population, and include RPM in there, I can certainly help you with that. And then, you know, we're assuming that, you know, again, without any more information to go off of for the $500 million for the USDA Emergency Rural Healthcare Program, that there might be some allocation of funds or you know, eligibility for remote patient monitoring, especially since rural areas, you have a harder time accessing healthcare, and it's much easier to you know, track patient data and deliver that to these rural health clinics or possibly to a more metropolitan area to observe patients, you know, without having them needing to travel, you know, 1 to 2 hours back and forth at their own cost, you know, to receive healthcare. And then
Thank you.
Lastly, you know, the Hersa funds it's definitely a very discretionary, very expensive program. So if you have received those funds for your health system, you should definitely consider that an option as well.
That's awesome. Andy, we have a great question related to this use case. The question is, are funds available for care coordination for individuals at home with a subtext of non-medical coordination of caretakers? Let's see. And then also what type of bandwidth is required? We can address that later. Yeah. Okay. So
without the ability to clarify on that question, I can think of care coordination in terms of the software components. So that's definitely something where, like Denise was saying, workflows and integration of telehealth into workflows is a huge hot topic right now. Same thing with RPM or behavioral health. It's all going into the language of these programs to make sure that you know, the workflows function properly. Again, with the bolstering, you know, massive increase or just the start of a telehealth solution for your health system to go to your patients. So I would say from a software perspective, absolutely, care coordination is going to be key to making that telehealth solution effective and usable by the healthcare professionals as well as the patients. Typically for headcount, if you're talking about people that can be put in places to manage the extra workload, most of the programs we've listed today do not allow for that. I can go into more specific details of which programs may allow in some part, but really the Hersa program is the only one that I found that's going to allow for more of the headcount for care coordination.
Great, thank you. And we have another question. How can you provide, sorry, my little text box is small here, so bear with me. How can you provide rural health patient monitoring without the data infrastructure to support it? And what type of bandwidth is required? So I think that's something that we can cover as we're talking through the infrastructure piece. Maria, does that sound good to you?
Yes, absolutely. And probably it's going to be on a case-by-case basis, and because there are solutions for every type of bandwidth or every type of community that we have encountered. And so yes, let's address, we'll address it towards the end, and then we can kind of take it offline with the person who asked that.
Sounds good. I think that's related to, very rural communities and connectivity and bandwidth, right? So, okay, great.
Yes. And also, I did want to maybe clarify could be a question in regard to remote patient monitoring and care. We have an Iron Bow, I know because I've worked with them on this before, has the ability to send out the components of a solution that go beyond just monitoring. For example, anything that, to take temperatures and scopes and blood pressure to be integrated into what Megan said, into the healthcare system that provider uses. So it goes beyond just monitoring and maybe what as a telehealth call. It could be more of almost like a clinical doctor's appointment where you're getting a lot of that, the stats you need. So remember to, in your mind, to expand what you actually need so we can make sure we cover everything if we have further discussions.
Great. Perfect. All right. And then there was a question from Deborah. Thank you, Deborah. I love how active you are on this. I think she had a hard time understanding Hersa. Andy, can you explain what Hersa is very briefly, and then we'll move on to the.
Sorry, I've said that acronym probably like 100 times now. It's just become kind of second nature to me. Hersa stands for the Health Resources and Services Administration. It's another group that focuses on grant funding similar to the USDA for the DLT program. The Hersa funding that was recently announced was for H8F designated locations. There should be information online. You can just type in Hersa H8F funding, and there should be some articles as well as a searchable map where you can go through and see if your organization may have been funded. There will be a short application after that, but we'll go into more of the details of that specific program for use cases if that's something you're interested in as well.
Awesome. Thank you. All right, great. So the third use case is less typical, but I thought very thought-provoking, is we like to address, again, the entire care continuum. So some of our customers leverage transfer or call centers to route patients to higher levels of care, say from their community hospital partners, or some of our clients, say affiliate partners that they contract with for specialty services that aren't necessarily available in their location. Or they leverage these transfer centers for bed management and also for referring into physician practices. Sometimes those physician practices are, employed or affiliated with, the larger mothership hospitals. So, trying to keep satisfaction, keep patients, close and contained within that particular hospital and those physician practices or hospital system. So this is really around patient navigation, right? And we're thinking about, from a financial ROI perspective, again, we want quality outcomes, and we also have the business side to contemplate for, and making sure that we're not, leaking patients out into competing health systems or hospitals, et cetera. So Denise, this is a kind of a unique one, as I mentioned before. Would love to get your take on this from a clinical perspective and why this might be something that our audience could contemplate for with leveraging grant funds.
Sure, thanks, Megan. So as she mentioned, not all health systems utilize a transfer or contact center, but most of the larger health systems do have the capacity to do so. As she said, it could be managed, it could be a way of them connecting to find out availability of a specific type of patient, like, a stroke patient that may need a more academic interventional type of facility versus someone that just needs basic intervention and diagnosis and assessment. So I've seen this utilized a lot, where the transfer center sets up like an assessment and referral center within it, where they're able to take in help with throughput for behavioral health patients especially. An example would be a behavioral health patient comes in, they have a team of assessors whether it's a certified RN in the behavioral health space or a social worker that's able to, like I said, do some intake information, do an interview of the patient, and then decide whether it needs to be escalated to a psychiatrist, psychologist, or they can discharge them back into the community to inpatient psych center, maybe to a bed if they have some medical issues going on in the facility. But again, the key here really is just triaging and setting the expectation that they are discharged appropriately with the appropriate instructions and follow-up, versus them being transferred somewhere just because, we can't, the intaking facility doesn't have the level of care. They may transfer them without doing this due diligence, and the patient isn't going to get the level of care that they should have gotten at the facility they transferred them to. So it's all about cost avoidance, also return on investment by getting the patient to the right place and with the appropriate quality of care, and then avoiding unnecessary transfers.
Awesome. So it's really great for satisfaction, right? And then also community public health and certainly retention, as you were mentioning. So Andy, let me transfer to you, and I would love to hear what grants might apply for this particular use case.
I love being the bearer of good news. Again, this is something that, behavioral health is the keyword that I got from Denise, as well as the consults for more specialized medicine. That's going to be the key use case here, just kind of in a nutshell. And really, again, all of the opportunities that we've listed today will, as long as telehealth, like live video, is being used for that consultation, all of the programs that we've mentioned today would be applicable for that. Because again, it's going to reduce impact on the emergency departments if for some reason there is a miscommunication and a person is kind of oriented toward the acute healthcare wing as opposed to a more appropriate inpatient setting. Behavioral health, I think, is again just kind of a core facet of a lot of these areas, because I don't have any objective data to support this, but I think we've seen in quite a few articles written in the last year that mental health is being more often ignored than physical health. And there is just kind of this acknowledgement that more funding and more use cases and solutions need to be provided for that. One other just kind of small anecdote here is that, we've seen that in rural areas, especially, accessing behavioral health services in a more specialized setting remotely actually leads to an increase in the uptake, even if there are mental health professionals in their area. For some reason, the anonymity of that experience is a little bit better in small towns where everybody kind of knows each other and sees where you're going. So I thought that was kind of an interesting anecdote that I completely did not expect. But to get back to your original question, all the programs we've mentioned today, including some others through, SAMHSA for substance abuse management, as well. Sorry, I'll spell that out. SAMHSA. Getting ahead of myself again. And then Hersa funding. There will be other programs that are dedicated toward behavioral health, as well as more of this specialized medicine consultation with consortium applications.
That's awesome. Thank you. Great info. So finally, for our fourth use case, want to turn our attention to the possibilities of care outside of the walls of hospitals and homes and focus on school-based telehealth. It's really important to note that this is a perfect way to apply for grant funding so that you can help your patient community and also enable wellness. So Denise, let's talk about how this is relevant from a grants perspective, but also from a meeting business objectives as well.
So this again is kind of meeting the patient where they are and keeping them in the community. Large health systems have all the resources that they need to be able to provide these services if they have these subspecialty providers within their team. So I look at it, I mean, school-based is one thing, but this is to include lending out your services to the urgent care facilities to free up some of the ED, the patients that are being transferred to the EDs unnecessarily that maybe could be cared for in the school setting, in the urgent care center. This helps reduce unnecessary transfers, as we spoke about, unnecessary leakage. This keeps the population where they belong. It's a proactive approach to care. Excuse me.
So Denise, so you talked about urgent care, which makes sense. So if I'm a kiddo and I'm in a classroom and I suddenly break out and I feel hot or sweaty or I have a rash or something like that, enabling a virtual program, right? So that the kid can be seen maybe at the school nurse's office, and that nurse is tapping into an urgent care physician, emergency physician, right, from their local facility or clinic, their partnering entity. Understand that use case. What other use cases would be relevant here in that school environment?
So again, behavioral health comes in to play a lot here as well. I mean, there may be a patient that's having a panic attack or has some anxiety or needs some medication management or things like that. A lot of children are suffering from social isolation with COVID going on and, haven't been exposed to school for too long and maybe they just need someone to talk to versus them being sent home for the day and all they needed to do was have a conversation with someone. So asthma management is another one, medication management, orthopedics, if someone falls and hurts their arm, maybe it just needs to be splinted and they need to be sent home and a follow-up orthopedic appointment needs to be scheduled, which would happen if they went to the ED, but the school nurse isn't comfortable in making that assessment and level of care. So they could pull in the specialist to provide that care.
Got it. It conjures up a memory I have of my big fat Greek wedding where there was Windex. You just spray Windex and it takes all of the pain away. So probably not a great plan, but definitely virtual care. Yeah. All right, awesome. So Andy, what kind of grants would be perfect for this particular community-based digital program?
So starting out with FCC COVID Telehealth, unless the schools themselves, like the physical locations, are kind of ordained as community health centers, they're labeled as such, this wouldn't be an eligible use of funds. So you just want to make sure that if you're planning on this type of project, you want to make sure that those schools themselves are listed as community health centers. We've seen a couple that are listed as such on that Hersa, HRSA website. And you can look through to make sure that those physical locations are indeed set up as a community health center before applying. USDA distance learning and telemedicine, again, the focus is on rural and impoverished populations. There is a major focus on school-based health as being an opportunity to create these outposts, like Denise said, for triage, the opportunity to access some lesser form of care to determine whether you need to access more specialized care or more serious care. And I think it provides a great opportunity. We've seen success in many applications over the last 10, 15 years, specifically for that use case. And if I can call out a favorite group of mine, the University of Mississippi Medical Center, they've done that before these visits through schools were even reimbursable. And you know, I think they were one of the first groups to become reimbursable for that service. And I think for a while they were the only one in the state of Mississippi that would be eligible for that reimbursement. I think with the expansion of reimbursements for this, it does make a lot of business sense as well. Now you can increase your patient populations, you can get reimbursed for that, and you can improve the standard of care and patient population health all the while. Let's see, there is one specific program that I didn't bring up today from HRSA, Hersa, that was in the title called School-Based Services. They had an initiative that was meant to be spent, the funding was meant to be spent on expanding school-based health. That has since gone by, so unfortunately we don't have the opportunity to apply for it this year, and that's why I didn't mention it on the program. But next year, I believe that should be out, or maybe in the next year. Sometimes they're 2-year programs, but it's becoming more of a topic, and certainly more funding opportunities will make that as an eligible use case.
Great, thank you so much. And I'm keeping an eye on time, so I want to, you know, again, give you some time, Andy, to talk about our next topic, which is how can folks actually qualify and secure this funding? If I know, again, it's going to be a high-level overview. Might make mention here that one of the things that we're going to do post this webinar is to conduct some office hours. So we're going to follow up with all of you and help you understand when Andy is going to make himself available, you know, for a block of time, so that you can either, you know, participate in a group discussion with others. And I have found that is very, very helpful, because people can generate ideas, and it's what I call a wisdom of crowds. So that's an option for you. And then the other option would just certainly to be, you know, set up a one-on-one, as Andy mentioned previously. So before any of you may have to drop to your next meeting, just wanted to make mention of our follow-up steps there. So Andy, high level, qualification and securing of funding.
Sure. So to start out, for any of these programs, the first thing that I do with your organization in mind is look at the eligible list of applicants. So determining whether your organization fits into an eligible applicant that can apply for funds, and then looking at the use case, you know, the eligible uses of funds, and the priority focus areas. So starting with the FCC COVID Telehealth program, that's going to be centered around a list of applicants such as nonprofit or not-for-profit hospitals. So for-profit hospitals cannot apply for that funding unless they are designated as a teaching hospital. So there's a bit of a caveat there. It's a bit of a matrix sort of ordeal. So again, I can walk through this with any of you guys if you have any additional questions, or just want me to look at your organization and figure out whether or not you can apply for it. It's simple as that. The
Andy,
next category.
So, quick question. So if the mothership, right, the hub, we call hub spoke model, if the, you know, let's say the urban center has a specialist and they want to create an outreach into their community hospitals, can a community hospital kind of join a consortium of sorts and actually apply for the funds in order to receive those specialty services?
Absolutely. For the COVID Telehealth program, you just want to make sure that each physical location has filled out a certain form. We're going to get really into the weeds if we go much further than that, but each physical location does have to fit within the eligible list of applicants, and then we have to make sure that they're kind of aligned with the program with certain registrations that they fill out before the application is submitted. That's a good question, though. So along with nonprofit and not-for-profit hospitals, teaching hospitals, there's also skilled nursing facilities and any academic institutions with a healthcare focus for their schools. So like a medical school, nursing school, or even a behavioral psychology school, again, with that behavioral health aspect. Moving to the eligible uses of funds, this is going to be strictly for implementing a telehealth solution. So we're not looking at indirect costs or FTEs that you can add to the budget. It's really strictly going to be for the hardware, the software, and the licensure for telehealth solutions. Some of that can include the workflow, as we mentioned previously. The maximum award per application is $1 million. And the great part of this is it's a 0% match requirement. So you basically get the ability to reimburse up to $1 million for your expenditures. And you have pretty much zero financial liability. That is, if you spend all the money in the right way. If you spend it on, Coke machines and stuff, you got to pay that stuff back. So moving on to the USDA Distance Learning and Telemedicine Program. Again, that's an annual competitive program. So we've seen that for the last 20 plus years. This year, they're receiving anywhere from 60 to 65 million. It's set to open in early April, and you have about 60 days to apply for that. So we're expecting a due date of early June. Eligible applicants, it's pretty wide open. You could be for-profit, nonprofit, rural, metropolitan. It's really just whether your end user sites, your physical locations that you're serving, are in those rural and impoverished areas. And anything under a population of 20,000 as a site is going to qualify. You typically want to go lower in populations to improve your objective scoring. Again, we'll get into the details on that later. And then the impoverished populations, obviously the higher the poverty, the higher the objective score is going to be. Eligible uses of funds, again, will be really for capital expenditures related to hardware and software, and must include live video as a component. Obviously, for telehealth or distance learning, and you can even use that for continuing medical education credits. That can be used for the distance learning component, even if you didn't want to have telehealth as a solution for that, but you're a healthcare provider. Max award per application is $1 million, but that does require a 15% match requirement. So if you can think about that in terms of a total project, $1 million in federal funds, $150,000 in match equals $1.15 million for your total project. And again, the due date is expected in early June.
And Andy, which program were you talking about?
That's for the USDA Distance Learning and Telemedicine Program.
Got it. That question from Eric, hope that answers that for you. Okay, thank you. And by the way, so Andy, I hate to cut you off.
Sure.
But lots and lots and lots of opportunities to discuss with our attendees and any of their guests that they may want to invite. I wanted to be able to wrap up and give Maria some time to really talk about how to operationalize virtual services. Maria's got a lot of experience, as you heard in her introduction. So with that, just to wrap it up, Maria, let's talk about infrastructure and.
Yeah, absolutely. And this is kind of a busy slide, and happy to send it to anybody. Pexip does a lot of things on the administrative side as well as the telehealth, telemedicine slide, and this kind of shows all of our touch points. But a question we always get is, how can Pexip handle all these virtual care interactions? I mentioned earlier about 50% that are conducted out there, and I've never heard of Pexip before. And the reason is that we're a video engine, not unlike an engine in a car, and we allow other parts to work, right? All these things that you see on the slide. So we're just look at it as a platform, and we're customized a majority of the time and branded by customers and partners. So we have some of the largest healthcare organizations really in the world that use Pexip, but it's branded for them, so you don't know it's us. So we not only work in telehealth and telemedicine, so just think inpatient consultations, patient sitting, medical carts, or the engine that's making all that work, room systems, emergency care scenarios, or anything that requires high quality secure video. And so the quality of our video is really to be reckoned with. And it's so flexible due to APIs and our integrations into things that you see here that, we're known for having specialists be able to have a clear and precise image in acute settings and workflows. So for stroke patients and things like that, when we're beaming people into help, they can make sure that they can see clearly and have what we call adaptive composition, which we can talk about if we have another conversation. So just a couple of our feature highlights are also an integration to Epic and some other EMR systems. Like I said, customized applications development, Microsoft Teams for you IT people that are concerned about that sort of thing. One touch join, we can allow joining from any video system you already have with just one touch, which is very powerful. So in a wrap up, we deliver investment protection, security, scalability, and an experience that's expected by large healthcare organizations or smaller ones that need to provide, obviously very concise care. More than just an off-the-shelf video system out there. So this is, an engine and a platform. So we obviously are well known on the clinical side and on the administrative side for conference rooms and such, but we also make the IT folks very happy due to our security and scalability. So I hope that covers it.
Yeah, that's great.
You,
the bandwidth piece, that's something that Pexip really can address, I think, in a little bit more detail. So we'll reach out to the folks that were asking that specific question, and we just want to make sure that you understand what's possible for you. So that's a wrap. We're a minute over. We really appreciate your time, everybody. Understand it's valuable. Hope you gleaned some really good information, and we will follow up not only with recorded session here, but certainly an opportunity to again engage with Andy and the team on in his office hours, as well as one-on-one. So thank you again. Have a wonderful
thank you,
rest of your
everybody.
day. Thank you.
Thanks all.